We're going toward the blood thinners and this implication for an fractured femur. I must say I am really thankful and happy that I got this opportunity to speak about this at this podium. Thank you very much. Thank you very much, Dr. Girish and the team. Now we all know that I'm not going to bore you with the theory, but we all know about the drugs that they are reducing the blood clotting mechanisms. But important drugs are warfarin, enoxaparin, fondaparinux, dabigatran, apixaban, rivaroxaban, ecosprin, tyrofibavin, clopidogrel, prasugrel, and ticagrelol. We all are facing this, each and every patient who's our geriatric patient and having a multiple comorbidities. These are even plasminogen activators, which are very advanced, but then not really that common. This is the guidelines which has made us a topic over here. This is the guideline about giving combined spinal epidural in a patient who is on antiplatelet or an anticoagulant drug. So this guideline says, if the anesthetist wants to give spinal on epidural, then we have a timeline. Now why I'm stressing on this, we'll come to know in some time. Prophylactic dose of LMW, that is Clexane, we have 12 hours before we can give it, and then after 4 to 6 hours we can again give it. If it is therapeutic dose, then we have to wait for 24 hours. If it is fondaparinux, again we'll have to assess the renal function and then decide the time, which is more than 24 hours. Warfarin, again 5 days. The best part of warfarin is PT INR is extremely confirmatory about warfarin effect on the blood. So PT INR less than 1.5, we can easily go and give spinal epidural anesthesia. Rivaroxaban, apixaban, edoxaban, all are for 3 days, 72 hours. Dabigatran is slightly more potent and it has got a lot of effect on the renal clearance. So if the creatinine is normal, we can wait for 72 hours. If the creatinine is not normal, I mean GFR is less, then we'll have to wait for 96 hours. Ecosprin, there is no restriction. If it is 75, just go ahead. Or if it is 155, there is a strong reason why ecosprin 150 milligram is given. So find out the reason, convert into 75 milligram, and then start with Clexane, and then we can go ahead with the surgery. Clopidogrel, prasugrel, ticagrelol, all are minimum 5 days. Out of it, prasugrel is 7 to 10 days because it is more potent. Now the important point is all these things are important for if anesthetists want to give combined spinal or an epidural anesthesia. This has got nothing to do with the general anesthesia, right? So this is very, very clear point out of it. Now if we see why anesthetists are scared about giving an epidural or a spinal, if we see on the antiplatelet drug, any kind of drugs, epidural hematoma is 1 in 1,50,000 and spinal is 1 in 2,20,000. So generally anesthetists stay away from the epidural in such patient, and spinal is slightly more safer, and the best recovery possible if any kind of incidence is reported within 8 hours, though 38% patient only get recovered. I have not seen personally epidural hematoma, but every major institute has reported. Now the problem or the conflict comes when the femur guidelines, if we see, femur is in a semi-emergency surgery, all femur fractures, and all the orthopedic association across the world has mentioned that it should be fixed in 48 hours, maximum 72 hours. In fact, our anesthesia association who has studied the morbidity, mortality for femur fracture, we also agree that this fracture has to be fixed within 48 to 72 hours at the most. So now where is the catch? Catch is this clopidogrel drug. Now this drug is very commonly used because the incidence of cerebrovascular accident has increased into the population. So each and every patient who has a slightest of this is on the clopidogrel. So what is ideal? Ideal is 7 days. Acceptable is 5 days. Now, if we really want to understand the platelet function physiology, 4th day looks to be a very, very safe on the basis of the production of the platelet every day and destruction of the platelet. So, say for example, if I want to go ahead with the spinal anesthesia in such patient on the day 3 or 4, for whatever the reason, I have to explain the risk of spinal hematoma and possibility of the spine exploration if that hematoma happens and does a paraparesis to the patient. This is the catch, and that's why we don't want to explain all these things to the patient, and that's why we try to delay the surgery for 5 days. But if, say, for example, patient is fit for GA. Now, if patient is fit for GA, then definitely this patient we can go ahead on the day 3 or 4, and with the definite bridging of a low molecular weight heparin, that is a Clexane group of drugs. And if we want to do such, then I would request that involve your anesthetist from the day 1, because to assess the requirement of clopidogrel stoppage will be on the decision or is on the indication of the clopidogrel started. For that, immediately seeing the PAC and all, it required a team approach, and the video PAC is what our team has started, which makes a lot of difference to that. If somebody asks me, there is no clear antidote of an clopidogrel. Platelet transfusion can do wonders if there is an excessive bleeding, but prophylactic platelet transfusion is not advocated in any of the articles so far. I have not seen any excessive bleeding even if we have given anesthesia on day 2 of an clopidogrel. So there is some catch with the Asian population and in the population which the guidelines are made in the European and Western populations. This kind of algorithms are there. I am not boring with you, but then this algorithm says that even if patient having a cardiac stent done recently less than 6 weeks, we had gone ahead with the fracture femur treatment by putting patient on the Clexane, high dose of Clexane, and keeping ready platelet transfusion. So there is no restriction about not operating the femur fracture. So what is the crux? Crux is an ask the anesthetist to see the patient and find out the reason for antiplatelet, anticoagulant drug indication of this clopidogrel, and put the patient on LMWH and adjust the dose as per renal functions and try to keep the patient as early as possible for femur fracture fixation. So the debate comes between a GA versus regional anesthesia. Most of the anesthetists or most of the surgeons also prefer to have a spinal epidural. That's why we delay the surgery. But as and when the GA is equally safe, please have a debate with the anesthetist, but keep the patient, relatives, and the physician also in the same loop. Otherwise, the physician who is leading the complication post-surgery will not agree that this fast surgery, why this fast surgery has been mobilized. Counseling and consent of spinal hematoma is extremely important, and we have one myth that blocks are very safe, but I would say deeper block of lumbar plexus are equally dangerous for an hematoma formation. Superficial blocks are fantastic to do, and we should give all superficial block when the patient arrives with the fractured femur, because that reduces the perioperative cognitive dysfunction, hyponatremia, and chances of pulmonary embolism, which is clearly supported by all the literatures. So if we are thinking that the PT-INR is an independent investigation, then PT-INR has got no role on the majority of the drugs except the warfarin. So this cannot be taken as granted that PT-INR is normal. Rivaroxaban, that is Xarelto, Eliquis, will have that antidote, that is Adnexate alpha, and Dabigatran will have an antidote, that Idaruzumab. But these are the costly drugs, like right now 1 lakh rupees around. But I hope that these drugs will come into us with very good rate, so then we can use it. And the only good news is that Indian Anesthesia Association is coming up with guidelines where we can easily use spinal epidural anesthesia on day 3. There are research is going on, because all the guidelines which right now we are following are Western and European guidelines, which doesn't fit in Indian population. So we will be having these guidelines soon, and that will solve our problem to the large extent. Thank you very much.